Okay, we'll go ahead and get started. Welcome everyone to today's webinar presented by SAMHSA's Game Center with the support of the Substance Abuse and Mental Health Services Administration. Today's webinar is on proceeding with care, reconsidering drug testing protocols for treatment courts. And our presenter today is Wes Huddleston, and I'll introduce him shortly. I'm Dr. Melissa Stein, a Senior Project Associate at Policy Research Associates and SAMHSA's Game Center. And you'll see a chat box icon at the bottom of your Zoom platform. I see a few of you are already saying hello. So hello, and yes, please do take time to introduce yourself, share where you're joining us from. And I'm joining from outside of Charlotte, North Carolina. Before we start our presentations, I'd like to cover a few introductory items. First, the views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the U.S. Department of Health and Human Services. And if you have any questions for the presenters or in regards to the technology, please type them in the Q&A pod, and you can see the icon for the Q&A pod at the bottom of your Zoom platform. At the conclusion of the presentation, we'll answer as many questions as time permits. And we're also conducting a couple of polls throughout this event. You should have just seen a poll pop up, so please select and submit your responses. We are recording this webinar, and the recording will be shared on SAMHSA's YouTube channel. And anyone who registered for this webinar will receive slides and a link to the YouTube channel when that is available. A certificate of attendance is also available to be downloaded at the end of today's webinar. Please note that this certificate is for personal portfolio use. We're not able to issue CEU credits. We do have ASL interpretation today. Our interpreters today are Pamela Mitchell and Dave Gratzer. We also have live captioning. To view live captioning, click the CC icon at the bottom of your Zoom platform. And we are really pleased today to have Amy Romero providing some opening remarks on behalf of SAMHSA, and she'll be followed by a presentation from today's speaker. So right now, I'd like to turn it over to Amy Romero, who is a public health advisor for the Center for Substance Abuse Treatment at SAMHSA. Amy.
Good afternoon. Welcome to today's webinar. We have a very important topic today. Some participants in treatment drug courts have extensive histories of trauma, and those with substance use and/or mental health disorders are often impacted the most. Without a trauma-informed approach, drug testing could add further trauma to participants, impacting the effectiveness of evidence-based practices and interventions. We are very excited today to have Wes Huddleston to help us examine how trauma-informed approaches to drug testing practices may improve participant experiences and even program outcomes. We would like to thank the Gain Center for all of their efforts planning and coordinating this webinar, and thank you all for joining us today. I will pass it back to you, Melissa.
Thank you, Amy. And now I'd like to briefly introduce our speaker. Wes Huddleston is a nationally recognized Justice Association executive, business leader, author, keynote speaker, and pioneering force in justice reform. For more than 30 years, he has advanced innovation and evidence-based practices across treatment courts, community corrections, child welfare, and clinical systems. Wes currently serves as Chief Growth Officer at Hoan Health, where he leads national growth and strategic partnerships to expand access to integrated physical, behavioral, and social health care for the vulnerable and justice-involved populations. From 1998 to 2015, West held senior executive roles at All Rise, formerly the National Association of Drug Court Professionals, the world's largest multidisciplinary organization at the intersection of substance use, crime, and behavioral health. As a national steward of the treatment court movement, he helped spearhead a comprehensive public policy strategy that expanded treatment courts in the United States from approximately 100 to more than 3,000 programs today. And now that you know who is speaking to you today, I'd like to learn a little bit more about who is joining us for today's webinar. So thank you for participating in the poll. We do see about 40% of you joining from urban locations, and that's followed by 34% joining from rural locations. So that's really wonderful to see so many folks joining from rural populations. And we do have several people also joining from tribal lands, such as Reservation, Pueblo, or Alaska Native Village. Welcome. And then in terms of the role or organization people are joining from, we have a tie, which is unusual. So about 21% of you are joining from corrections, probation, parole, and 21% of you are joining from government or policy organizations. And that's closely followed by 20% of you joining from the judiciary. And we also see several of you joining us from community-based provider organizations and so forth. Thank you so much for your time today joining us. And without further ado, I'm going to turn it over to West Huddleston for our important presentation. West.
Well, thank you so much, Melissa, and my thanks to the Gaines Center and to SAMHSA for allowing me to present the need for trauma-responsive drug testing protocols and treatment court programs. This is a presentation that that I really kind of accidentally came across. To be honest with you, I was doing a presentation on incentives and sanctions in probably 2022. Pretty large group of individuals, you know, talking about the delivery of behavioral science and when and how to deploy positive reinforcement, negative reinforcement, incentives and sanctions, and therapeutic responses. And someone raised their hand at the end towards the question and answering period and brought up a case scenario where an individual was, quote, refusing to do a drug test or to void a sample for a drug test. It had happened a couple of times. And was asking specifically how, given my presentation, how they should respond. And I was curious to better understand, you know, the individual before answering the question. And the way they describe the individual as being frozen, unresponsive, despondent, and therefore unwilling to give a drug test sample. And that word frozen really impressed upon me, having done, you know, quite a bit of work in, you know, my former leadership of All Rise and all the training and technical assistance and the focus on treatment courts nationally being trauma informed, trauma responsive, and trauma sensitive, that I asked the question, is this particular individual, is it possible that they have a trauma history? And it was like a light bulb went off across the entire room. And we had a pretty amazing conversation in this presentation about the extensive potential triggering or re-traumatizing situation that an observed urine drug test can create for individuals that have trauma. And particularly, urine drug testing we talked about was inherently triggering because of just their loss of bodily autonomy, them being watched by an authority figure and that power dynamic in a confined space, and the removal of clothing and exposure. And it's like the entire room's compassion kind of kicked in. And I left that presentation, frankly, my friends, a little bit ashamed that we had spent so much time at All Rise and focused on trauma, focused on just the prevalence of trauma among our population, not just in treatment court, but across the justice system. And that we really had never tackled how re-traumatizing potentially an observed urine drug test could be for some individuals. Just we describe it as shy bladder, right? And under many policies and procedures across not just treatment courts, but community corrections and even corrections broadly, it's punishable, right? To not give a drug test, for it to appear to be refused. So I went about and I asked a couple of people that I knew in the field, really experts in trauma, to do a lit review for me. And so they did a lit review on anything that could potentially encompass the literature at that time on trauma-informed drug testing. And so I'd reached out to Dr. Philip Breitenbucher and Dr. Jerry Middleton, and we found that there were 0 published articles on the term trauma-informed, trauma-responsive, or trauma-sensitive and drug testing. That was only 2 years ago. And so the 3 of us went about changing that. And we really sought to publish, first and foremost, a couple of articles to just bring awareness of what I just said, right? And so we started with a technical assistance brief that we wrote and published in 2023 for the Bureau of Justice Assistance at the U.S. Department of Justice, entitled "Implementing Trauma-Informed Drug Testing Protocols in Child Welfare and Family Courts," and that was published, and it's still out there to be found today if you work in those environments. But particularly, we started there just because typically, relative to child abuse and neglect cases in child protective services or child welfare, a lot of those mothers and caretakers and families have long histories of abuse and trauma. And so we really started there. And then our next publication was in the Drug Court Review, which is the treatment court or drug court journal of the National Treatment Court Resource Center. And in summer of 2024, this article was published, "Trauma-Informed Drug Testing Protocols in Treatment Court Programs." And if you work in a treatment court, I would highly recommend that you read this article. This article, it's a commentary article. It's not a research article, but it really dives very much and very deeply into the subject at hand today. I further published in the American Probation and Parole Association journal called Perspectives, an article in November of 2024 on this subject as well, and presented last year at the American Probation and Parole Association conference on this subject. So that's my quick journey into kind of how this subject came about, and I'm just very honored and grateful to have the opportunity to share some thoughts with you today, and really appreciate this opportunity and for everybody tuning in. So let's start with the acknowledgement of the problem before we take on the solution. So just when we talk about trauma and we use the term trauma, it's important to understand the impact of trauma on individuals' behavior. And so individuals that have a history of trauma are 15 times more likely to commit suicide than the population that does not have a trauma history, 2.5 times more likely to smoke tobacco, 3 times more likely to have serious job problems and experience depression, as well as be on antidepressant medication and experience multiple absences from work. 4 times more likely to inject drugs, to experience an alcohol use disorder, and to develop a sexually transmitted disease. So trauma historied individuals are at high risk, and oftentimes do not understand that they are traumatized, and we're going to talk about that in a minute, or much less that they could have freedom from the symptoms that they have experienced for so long. When you look at the literature around the nexus or the intersection between trauma and justice-involved individuals or individuals that have a substance use disorder, we see that trauma is remarkably present, and to the extent that it's almost universally experienced in this population. That's actually a quote from the literature. And although only 6% of the adult US population has trauma history, 95% of individuals with a substance use disorder have a history of trauma. So I think you would agree, if you're on this webinar, if you work in the justice system, if you work with justice-involved individuals, or if you work with individuals with a substance use disorder, you would agree that the vast majority of your clients are trauma history. And SAMHSA defines trauma as physically or emotionally harmful events with lasting adverse effects. In my experience and working with this particular justice-involved populations, both incarcerated and in the community, I can tell you that these events are, at least to the individual's experience, life-threatening, oftentimes very complex and ongoing, and that it is the body's exposure to extreme horror that creates a state of terror, and it creates a state of terror in the individual that just never lets up. And so the people that are untreated for a post-traumatic stress are oftentimes stuck in a stress response and a trauma reaction, and it is a central nervous system reaction. Therefore, it is not a choice. It is not a choice, but yet a central nervous system response in response to trauma and in response to the things that trigger those trauma responses. So for someone with trauma history, it can, these events can activate the central nervous system survival responses and really tell the body that they are in a genuine present threat, even though they may not be. And so we've heard fight, flight, freeze. I want to talk very quickly about the 5 responses to trauma that we typically see among trauma history individuals. And that is fight, flop, fawn, freeze, and flight. And so I want to put this in the context very quickly of what you as professionals would see in a drug testing environment across these 5 responses. So in fight, what you might see is someone that has aggression, defiance, verbal hostility, refusal, which we talked about earlier, arguing about the process, maybe accusing you of violating their rights, so accusatory language, or even physical aggression. What's actually happening inside that individual in that fight response is their central nervous system has identified this drug testing environment as being a threat, and therefore their central nervous system is mobilizing them to confront and overpower it. And this is not manipulation. It's not non-compliance as a choice. Again, it's a physiological survival response. And so when a participant suddenly becomes combative at a collection site, our first instinct might be, hey, they're hiding something. They're just trying to get out of the drug test. When in actuality, trauma-informed thinking asks us to consider whether they're actually surviving something instead of hiding something. Under kind of the flight response, what you might see somebody in the flight response mode is that they attempt to leave, or that they no-show, or they cancel, or they arrive late, or they leave right before the test. They may be looking at exits, or fabricating excuses to avoid the test entirely. What's actually happening in their central nervous system is that they've identified this situation as a threat, and therefore they need to escape. They need to run away from it. Avoidance of a drug test might be less about evasion and more about a trauma experience, or avoiding a trauma experience. So we reframe that from a trauma-informed place and a trauma response place, and we acknowledge that they may be terrified. And our policies need to account for the difference between a participant who keeps missing their testing window because they're using versus because they're terrified. Freeze. Let's talk about freeze a second. We see freeze a lot, especially in this particular environment of a observed drug test. What we would see is a participant who becomes still or unresponsive. They may shut down. They may stand motionless or be unable to produce the sample despite urgency. They may stare blankly. They may not respond to instructions, or they may even seem disassociated or checked out, quote unquote. And that actually is their central nervous system that has determined that fighting or fleeing is not possible. And so their central nervous system kicks into immobilizing the body. This is involuntary. It is a trauma response. It is a very well-known trauma response among individuals that have been sexually abused, raped, or molested. And this inability to void is a well-documented physiological response. It's not a stall tactic. And so the idea of a shy bladder is frequently not shyness. It's a nervous system in freeze. Let me say that again. It's a central nervous system in freeze. Fawn, the trauma response of fawn, as you probably are aware, is excessive people pleasing, over apologizing, hyper compliance, and it's just this nervousness masked by eagerness to please, saying whatever they think the drug test observer or the probation officer, or whoever it is doing the collection, might want to hear, including, and we've seen this, including admitting to using drugs in order to avoid the drug test, right? So, and we've seen that sometimes in clinical settings. What's actually happening in fawn is it's a relational survival strategy, right? Often developed in response to interpersonal trauma such as domestic violence or childhood abuse or coercive control, and the participant is simply trying to appease perceived authority to avoid harm. So when we see that a participant is overly agreeable and tells staff that they want to tell staff of what the staff wants to hear, or they seem almost desperate to please during testing, that may not be as much about their trustworthiness as it is about their trauma history. And they've just been taught through their abuse and their experience with trauma that compliance equals safety. So these are 4 signs and symptoms so far that we can see very clearly in a drug testing environment that would indicate that somebody may have trauma. The final one is FLOP, and it is exactly what it sounds like. It's a physical limpness, fainting, near fainting, sudden emotional collapse, crying without clear cause, the inability to stand or function, and appearing to fall apart. And it's oftentimes called the dorsal vagal collapse response, and it's when the central nervous system has essentially given up any active defense and has told the body to just conserve resources and shut down. And we see this in among animals when they're attacked by a predator. It can oftentimes look dramatic and be mistaken for either manipulation or a medical event. And in fact, it is the most primitive survival mode that the body has. And it is a true indication that the individual is severely traumatized. So the single most important shift that we need to make when we see these behaviors is to pause before interpreting a participant's behavior at a testing site. And we need to ask, is this person being difficult or is this person dysregulated? I'm going to say that one more time. Is this person being difficult? Is this person being manipulative? Is this person being dishonest? Or is this person dysregulated because of trauma? And we need to establish policies in our programs that distinguish between the two. Or we're going to continue to create harm and really get in the way of the individual's healing and rupture the therapeutic alliance that we've created across the rest of the team. And in fact, I'll go as far as to say that unless we treat the trauma and we help the individual get relief from their symptoms, they have a very, very slim chance of long-term recovery. And so that's what's at stake when we talk about why we should care about trauma-informed, particularly drug testing. Now, the symptoms of trauma, the individuals with trauma histories, they experience constant flashbacks and intrusive memories, very detailed memories of what happened to them. They are oftentimes in a state of hypervigilance and panic. As you know, they suffer from anxiety, irritability, anger, depression, exhaustion, because to be in that state at all times is exhaustive. And we oftentimes see individuals move to detachment or disconnectedness just to survive. They're in survival mode, my friends. And if not treated and relieved, they will suffer long-term chronic pain and illness. The body just cannot be in that amount of central nervous system stress without it creating significant physical illness, and pain. So we know that we use the term trigger a lot, that individuals can oftentimes who have these histories be triggered by sensory stimuli such as a smell, sound, sensations. I interviewed a lady that her mother, she grew up in and out of foster care, in and out of child protective services, and she would go with her mother in these outsourced drug testing collection sites, and be left in the lobby, and she was molested in the lobby at one of these sites. And here she is years later, in the same environment, being required to give a urine drug test herself, and bring her kids into that environment in which she was traumatized. So it was, we just don't know unless we're assessing and asking these questions, right? And so whatever symptoms we see are oftentimes as a result of these reminders, these sensory stimuli that individuals have, and we just can't ignore them any longer. The justice system has done such a great job, and I think everyone on this webinar today is here because you're committed to being trauma informed and trauma sensitive and trauma responsive. This area of drug testing is almost the last area in which we need to kind of clean up our house and really do some things differently for trauma historied individuals. I will tell you from a personal perspective and from a clinical perspective that people that have trauma and that live in this trauma response state that we described so far, they just want relief. They just want relief. And I would say, particularly the clinicians on this webinar would agree that when these triggers occur, when the central nervous system gets activated and we see the symptomology occur right before our eyes, particularly in a drug testing environment, that is a perfect opportunity to introduce treatment. It is the perfect opportunity to do EMDR as an example of one of many evidence-based treatment approaches to what they perceive as a threat or a place that's unsafe for them. And so it could literally be the catalyst for their healing and for the beginning of their treatment. So we need to be super aware of the responses that emerge, particularly when they're being urine drug tested in an environment that is triggering. So let's move to the solution. Our duty is to help them heal. I mean, it doesn't matter if you're a probation officer, parole officer, a treatment court judge, a clinician, whatever your role is, case manager. Our job is to help people heal and to resource them so that they never come back. That's what we're about. And so we can do better, particularly, I'm going to speak to treatment courts now. We can do better when it comes to just being trauma informed and trauma responsive. We in treatment courts, and I also know this in community corrections, have adopted a lot of trauma informed language and practice and changed our environments, and we're bringing trauma responsive treatment services to bear. I think about the environment of a veterans treatment court where there's a service dog, a trauma dog, there's trauma therapists, everyone is trained in being trauma responsive. The language is different. The language is empowering and encouraging and safe As much as a courtroom is historically not safe, we've made these courtrooms safe and therapeutic as much as possible. And I know probation departments and community corrections have done a lot of that work too, and even correctional facilities and some units. And so that's where we're winning, right? That's where we're doing such a great job. It is this last area of drug testing, and particularly observed drug testing, urine drug testing, where I think we have a lot of opportunity to move away from creating a feeling or maybe even the reality of an unsafe environment. And I don't know if you've ever done an unobserved urine drug test, but it is at a minimum shaming and humiliating and invasive. And as we talked about, potentially very re-traumatizing for people with trauma histories. Okay. So I was really proud that All Rise, formerly the National Association of Drug Court Professionals, my former organization, took this notion and changed the best practice standards that were published in April of 2025. Up to that point, there was no mention of drug testing being trauma informed. However, and I'm not going to read all this to you, but I'm going to start kind of where it says, however, according to All Rise, collection personnel exercise sensitivity to the invasive nature of observed urine testing and use trauma-informed collection practices in cases where there are significant concerns about the possibility of re-traumatization. And I love this last paragraph. Trauma-informed approaches may include adopted observation techniques, unobserved collection with precautions, increased dialogue with the participant, providing more time to produce a specimen, or alternative specimen collection where appropriate. That is a big step in a best practice standard. And what it does is it recognizes that the vast majority of people, in particular in treatment courts, because the vast majority of them have a substance use disorder and or other mental health or behavioral health disorders, have a trauma history. And so this pivot provides courts, treatment courts, the ability to explore what else can be done for these individuals. And it's very consistent with the 4 R's of trauma-informed care put out by SAMHSA. We realize the widespread impact of trauma and understand the potential paths for recovery. We recognize the signs and symptoms of trauma in our clients and their families. We respond and we resist re-traumatization. So we shift from what's wrong with you in this environment to what happened to you. And that's the magic. That's when the magic happens. That's when healing can begin. So back to our duty to help them heal. We, the authors of these 3 publications, and now kind of an army of professionals that have taken this on in their programs, believe that implementing trauma responsive drug testing solutions can enhance engagement and it can reduce program dropout rates, that it's going to get clients that are in this storm of trauma response and this pain. It's going to get them to lean forward and to trust you deeper and to trust that we're not there to harm them, that we're actually there to help them heal, and that healing is possible. And they need to hear that. So we did a crosswalk between SAMHSA's trauma-informed care principles in the articles that I mentioned at the top of the presentation, and the National Drug Court Institute and other trauma-informed and trauma-responsive principles. And so I want to call out a couple of those and talk through them with you. So SAMHSA identifies the key principles of trauma-informed care as being safety, trustworthiness, and transparency. These are client-facing, client-oriented. The importance of peer support, collaboration, and mutuality, and empowerment and choice. I'm going to start a little bit out of order. I want to talk about peer support and how critical it is. And I hope that everyone on this webinar and your programs, whatever your program is, has peer support, because interpersonal trauma is fundamentally a wound inflicted in relationship. So whether it's abuse or neglect or violence or coercion or abandonment, all were experienced between people. And so the theory in trauma treatment and in particularly peer support as a part of that process is that healing must also happen in relationship. And that a peer support specialist who has lived experience with trauma and trauma recovery is critical to ensuring that healing happens in relationship with other humans, with other people. Clients must learn that relationships with people, especially in authority, like we are in their lives in this moment in time, can be safe, that we can be safe and we can be a model for someone in authority that is safe for them. That is healing. So I would stress, number one, peer support. And then to look at these other key principles of trauma-informed care a little bit closer. Sorry, my slide seems okay. Let's just talk a second about risk and safety planning. So the principle is that we need to ensure that, back to drug testing, that drug testing protocols are designed to safeguard the mental and physical well-being of participants and their families. So how do we safeguard the mental and physical well-being of participants and their families? Well, we first need to know absolutely whom among our clients have trauma. So we have to start there. We have to start with screening and assessment. And, there are multiple brief validated tools that can not diagnose, but would screen for the prevalence of trauma. 3 of them that we're probably all aware of is the Adverse Childhood Experiences questionnaire called ACE, the Trauma History Questionnaire, also known as the THQ, and the Primary Care PTSD screen for the DSM-5. Those are screening tools that are self-administered and are validated and are very good at screening for the prevalence of trauma. Then when someone, where an individual is deemed to have the prevalence of trauma, then it's really important that we have trained clinicians that can do targeted clinical assessment. The PTSD checklist for the DSM-5, also known as the PCL-5, is a self-administered targeted clinical assessment. The gold standard is the PTSD scale for DSM-5, or the CAPS-5. That is clinically, that is clinician administered. And so these are tools that we have to deploy in our programs to understand who is standing before us in a treatment court or on probation or in child welfare, or in jail or in a drug testing collection situation. And so we first ensure that we know who needs to be safeguarded, right? And then we go about working to ensure that they have the right environment. And that environment must be safe. It must be safe. That drug collection environment must be safe for them. I would say it, particularly those that have sexual abuse history, sexual abuse trauma, rape, molestation, they need privacy. They need privacy and they need control and choice as to what occurs with their body. And so we need to give clients who have those histories privacy and to give them the ability to choose the testing methodology. Now, this is where, if this was a live audience, I would start getting shoes thrown at me because that's not how we do things in the justice system. But in order to be trauma informed and trauma responsive, this is what it takes. It takes us to give the client the ability to choose their methodology or to pause when triggered and to get them an intervention. We also need to be highly transparent, and SAMHSA talks about these as well. We need to be trustworthy and transparent with them to explain, why are we drug testing today? How can these drug test results be used to prove that, to prove to the team that you are clean and sober today, and to be rewarded and celebrated for your recovery? Or if you're struggling and you've slipped or relapsed, it is an opportunity for intervention. It is an opportunity for us to help you further, to give you more help, to untangle why you are struggling and to get you the help that you need. So that's what it means to create a safeguard and a supportive environment so that we're not re-traumatizing individuals. We also need to be very collaborative in how we do this. It's not enough just for one individual or two individuals that are engaging our clients to be aware of all this and to be doing it well, because it only takes one to unravel this and to unravel our therapeutic alliance and to rupture it. And so, this is where the judge or the probation officer or the case manager becomes part of the assessment ecosystem. That functional behavioral based assessment is really critical, so that everyone on the team, whether you're a clinician, a case manager, or an officer, a judge, a lawyer, that they're trained to observe trauma indicators, and they're trained to know the difference between emotional dysregulation and avoidance or non-compliance. It's critical. And so that's what this really means by cross-systems collaboration. And probably most importantly, my friends, is to ensure that we have good evidence-based trauma treatment available to individuals that we've identified that have a trauma history and are symptomatic. It is It is not enough to identify. It is not enough to just adjust our policies or procedures. This is the population that needs immediate help and treatment. And the beautiful thing about trauma treatment today, if you're not aware, is that freedom can happen relatively quickly. That symptomology, the central nervous system can relax and get out of a trauma response. And an individual that has a trauma history will learn once they address their pain and they do it with a highly trained trauma clinician, they can learn how to manage their symptoms and move into the present, right? To move into the present and to be connected and to feel safe. That's when real healing begins. And I think a lot of recovery, the foundation of recovery from a substance use disorder, and a lot of depression and anxiety gets lifted through that work as well. Finally, dignity and just worth of the individual, that we can introduce non-invasive drug testing methods that respect the individual's privacy, dignity, and their safety. These exist today. They're not all practical, they're not all cheap, but they are available. The first one is I'm going to share two. There's others, and I can address these in question and answer session. But let's just talk about urine collections. I mean, urine drug testing is the gold standard. There's no question about that. It is a better way to detect the presence of drugs and alcohol in the body than other methodologies. It's well tested. It is validated, and it stands up in the court of law. There is a way in which a urine drug test can be collected and matched to the individual without an observation. And the only way to do that is through a DNA matched urine collection. So there are laboratories that specialize in this. It requires a DNA mouth swab. That DNA or parts of that DNA that cannot be used against them, for future crimes, goes to a clinical lab, and the specimen can therefore be given. A urine specimen can be given without observation in the privacy of their home, and then sent to the lab, matched to that individual, and then business as usual. Results are supplied to the team. So this technology ensures that the sample belongs to the donor, and that there is no need for an intrusive or shameful or re-traumatizing human observation experience. So that's how to do it with a urine drug test. I've seen this at work. I know of drug courts and probation departments that use this for their trauma population, and it's highly effective. And all of those drug tests are obviously LCMS or GCMS confirmed in a laboratory, and highly reliable. The other methodology that I am a personal fan of, and it is cheaper, but it has a little bit different use case, is oral fluid collection. So when oral fluid testing is used, the collection can be unobserved, so long as it's facilitated via a recorded process and then viewed, authenticated, and confirmed by a proctor. So there are apps out there that will enable an individual to stay in the screen to do an oral fluid test, seal it, and then that oral fluid test is either taken into the drug court, for example, or the probation department, or it could be mailed directly to the lab. But that the observation of that swab and of that test is all done on a video, that's proctored. And so any attempts to substitute, a sample, for example, are identified. And obviously an oral fluid test can be done in person, right? And can be done live with an individual, and that is rarely invasive or re-traumatizing for individuals. But certainly I think this is an inexpensive and very doable solution. Obviously, oral fluid testing, the window of detection is very short. I'm not going to get into detection windows today, but the detection windows are short and much shorter than urine, depending on the drug. And so you just have to do more of it. You just have to do several a week versus twice a week. So, but that's the trade-off in figuring out a way to be trauma informed and trauma responsive versus putting somebody through a traumatic event and potentially getting in the way of their healing. So these are two very very real and viable solutions for trauma informed drug testing. I'll just finish by saying, and we'll open it up to questions, but I just encourage you to read the article in the Drug Court Review, or find the article in the American Probation and Parole Association Perspectives journal, or the one on child welfare. But any of these three articles that we've written really kind of go into depth more and really help, I think, any justice agency or organization, or even a treatment provider, redesign their drug test protocol to be trauma sensitive, trauma informed, trauma responsive. We want to absolutely reduce the risk of re-traumatization and ultimately help our clients heal. So with that, I'm going to allow for questions and kind of see what lateral learning we can do at this point. Thank you.
Yes, thank you so much. Let me get my camera working again. Okay, all right. So we do have several questions that have come in. Thank you so much, Wes, for covering so much wonderful information. And let's see. We will be sharing the slides. So if you registered for this webinar, we will share the slides directly to the email you used to register so that you can access those references and look up some of the links to the articles that were covered. So yeah, just want folks to know that you will get this information. So let's just dive into the questions. Okay, so I think primarily, West, one of the biggest hurdles we have in this conversation about teaching trauma-informed approaches, whether it's drug testing or really any other service that we provide within our criminal justice context, folks always are trying to figure out, is the person manipulating me, or is this a trauma response? And so I know that you talked a lot about evidence, symptoms of trauma responses. What do you say to that when someone says, I'm not sure if they're being manipulative or if this really is a result of trauma?
Yeah, I would say two things. I'm just going to restate two things. Number one is the prevalence of trauma among this population is almost universal. It is extremely high. It is who you are engaging on a daily basis. It just is. And so that I think accepting that as as truth with a capital T. The literature bears that out. And I think the vast majority of us have been in this field for as long as we have. We just know that to be true. The second thing is, please screen and assess for trauma. Take the guesswork out of it. Screen and assess for trauma so that you know exact, and this is part of communicating and empowering our clients and being an ally and a healer, a co-healer versus just somebody in authority. It is critical that we know who has trauma and particularly what type of trauma that they have so that we can adjust our treatment plan. We can adjust our drug testing protocols. I mean, our whole system of care should change based on somebody's diagnosis and history.
And I think that even if we are just doing a simple, some folks just do a simple ACEs checklist. Well, some folks, seeing their mother be hit by their father, they wouldn't consider that a traumatic exposure. So you might even have to do some educating around, what have people experienced, and they may not consider what they've experienced to be trauma, but they have seen some pretty tough stuff. So that is a big challenge that we face. And someone added a comment here that I thought was really interesting. And I thought, considering your personal journey you described at the beginning of this webinar, I thought you might have a response to this. This person said, how do we get past our own stigma of not trusting the client to be honest about the drug testing process? And so I thought that was really interesting that this commenter is owning that he is the person with the stigma of not trusting the client. That just really goes in line with what you were just saying. But I didn't know if that triggers any thoughts for you.
Yeah, I mean, I had the same experience. When I first, as I said at the top of this presentation, I felt like shocked. Like, how did I not see this? I mean, I pride myself in being on the cutting edge of what works and what doesn't work with people that are in these programs, and very steeped in the literature and in personal recovery, and still blind to them and seeing it as a choice, right? Versus seeing it absent that stigma, as this individual called it. It's okay. We evolve, and this has not been a conversation. I'm telling you, there has not been a conversation about trauma and drug testing prior to my knowledge, at least in the literature. And even in 25, 30 years of being in this field and running the National Association, had not heard about it, had not connected those dots. So it's new, and we ought to all be starting to talk about it. And I assure you there's going to be a lot of defensiveness and a lot of reasons why not to do this, just because change is hard. But it's time to change.
And so you started to introduce some potential solutions, some other options for programs to consider. And if you don't have this information, that's fine. We can follow up later. But a couple of questions came in about the DNA drug testing.
Yeah.
So someone was asking, do you have any sense of the cost for that type of testing? Is that feasible for a drug court to take on?
I agree. Yeah. Yes, I do. So the average cost is around $130 per test. It is a lot of money. I will say that the problem that drives up the cost is that DNA degrades very quickly in a urine sample. And so the laboratory needs it overnight. So there's a significant cost to overnighting to a laboratory. And there's a laboratory in Atlanta that does it. There's a laboratory in California that does it. I think there's one in Illinois. So if you're, close to a laboratory that does DNA authentication or authenticated drug testing, or verify, they also call it DNA verified drug testing, then it might significantly cut down on your cost. But average cost is about $130 a test. I'm going to say the other side of that, Melissa, and that is the cost of re-traumatizing somebody. I mean, I have to say that is a small cost compared to re-traumatizing an individual and them committing suicide or relapsing or continuing to pass on their trauma to their children, right? So the cost of it right now is, to me, not being an administrator of a program, but to me, it's worth the return.
Okay, and since you you said before making an assumption, assess them for trauma. Now, folks are wondering, do you have a good trauma assessment to recommend? And if you don't have that on the top of your head, don't worry. I'm going to pull up a resource from SAMHSA. But if you do have trauma assessments you would recommend, go ahead.
Yeah, I think SAMHSA is the expert in this, but so there are 3 screens that are validated and are good screens. First is ACEs, also known as the Adverse Childhood Experiences Questionnaire. Brief, but as Melissa said, because it is self-administered, they may not think that some traumatic events are traumatic, right? So there's some education that's required. Number 2 is the Trauma History Questionnaire, the THQ. The third is the Primary Care PTSD screen for the DSM-5. Those 3 are screening tools for the prevalence of trauma, and then follow up with a targeted clinical assessment with a clinician to deploy. I would suggest the PTSD scale for DSM-5, or it's called the CAPS-5, CAPS-5.
That's wonderful. Thank you so much. And I'm also going to just drop in the chat. This is a publication available on the SAMHSA store or SAMHSA library. It is screening and assessment of co-occurring disorders in the criminal justice system. And it does have a whole section on trauma. So it's got a section on mental health screens and assessments, substance use treatment screenings and assessments, as well as trauma. So another resource there in addition to the tools that Wes just mentioned. So thank you so much for all of those questions. There were other questions about the other types of drug tests that might be out there in the field. So someone asked, do you know anything about sweat patches being used for drug testing? Yeah, so sweat patch, I would say, is considered a trauma responsive methodology for detection of drugs. It is, I describe it as an external bladder, right? That's collecting, in this case, not urine, but collecting sweat over time, a week, 2 weeks. And so, the limitations of that is obvious, right? You're not going to know whether the individual has used or when they used, but you will know if they did use during that detection window, and it is, I would say, considered trauma informed or trauma responsive. There's also, nail and hair
for the same reasons. You know, I would say they're trauma responsive. Um, but there are significant limitations. Obviously, it's a look back in time, and there's a good use case for those. There's a good use case for, you know, oral fluid. So, you know, I probably would not recommend blood. Certainly for alcohol detection, there's you know, many other ways to detect alcohol, whether it's through a continuous alcohol monitoring device, or, you know, what they call wearables that detect alcohol through the skin, through sweat. Uh, Oral fluid is good for the prevalence of alcohol in the moment. So yeah, those are all, again, you need to dissect the use case, right? But I think those are all great tools and great methodologies for trauma history to individuals.
Okay, and one last question regarding testing. Someone asked, historically, have you noticed that oral swab testing leads to a higher rate of false positives? Is that something you feel comfortable speaking to?
I don't. I am not a toxicologist, and I don't want to mislead anyone there. So I would not want to comment on that.
Understood. Getting more back to our adult drug court best practice standards, you know, some folks are asking, if we know someone has trauma, should we try to accommodate that with fewer drug tests? Or, you know, if so, then how do we calibrate that? How do we determine what would be, you know, an appropriate level of testing? Someone asked, you know, if we're testing 4 times a week, is that too often? So just, you know, what are your thoughts around, you know, what's appropriate around urine drug testing for folks who have experienced trauma in light of the best practice standards?
Yeah, I'm just going to stress this again. I I don't think an observed urine drug test is the way to go for somebody with a sexual abuse history. I think so. I would say none, and I would find other methodologies to drug test them with that we've discussed. Unless you're going to use DNA authentication, that would be the only exception, right? So we've got to find ways in which, for individuals, particularly with a sexual abuse history, that they do not have to suffer through an observed urine drug test. There's other technologies and methodologies out there. So if I were doing oral fluid testing, I would want to do that about 4 times a week. And you can do that in person, you know, and I know that, you know, there are ways to circumvent all drug tests, and the way to circumvent an oral fluid test is to drink something or have something in your mouth. Part of that process, again, this is about communication and giving the client the choice, right, and empowering them and having transparency with them. That's all very critical with this trauma history population. But to explain to them, you know, you have to come 30 minutes before the test. You have to sit, not drink anything. We will look inside your mouth to make sure that you don't have anything. You know, you're gonna a drug test is important. It is court ordered or is a condition of release or whatever it is. We need to do it for many reasons. If you elect for oral fluid, here are the conditions in which you're going to do that. Do you agree? If not, let's find something else. So that, to me, that's the conversation. I hope that answers the question.
Mm-hmm. Yes. So now just kind of pivoting to, you know, building collaboration around this newer approach or this new consideration around drug testing. So, how could people go about getting judges on board, getting their treatment court team members on board to adopting more trauma-informed, trauma-responsive approaches to drug testing?
Well, I mean, there's not a lot of presentations like this, unfortunately, going on. So I think it's incredible that the Gaines Center and SAMHSA has selected this subject as one of their 15 national webinars for the year. And so I think the recording of this webinar, along with the articles that are in the slides, there's links to the articles in the slides. I am happy if the Gaines Center wants to send my email to individuals. I can send the links or hard copies, but I would watch this webinar with your team. I would read those articles and then maybe bring in somebody to facilitate how to pivot and shift toward policies and procedures that are trauma-informed, trauma-responsive, and trauma-sensitive. I don't think it's complicated. I just think there's resistance because this is just the way we've always done drug testing, right?
Mm-hmm.
But
yeah.
but that's been the same for supervision. That's been the same for treatment. I think it's very possible. I would hope in a year or two, this is just the way business is done.
And I will add that if you go to SAMHSA's website and search for the Gaines Center, and we will share the direct link to the Gaines Center later. We do have a page where you can look for people who have been trained in the Gaines Center's trauma training. And that could be a first step. If your court has never done or your probation office has never done a training on trauma and trauma-informed responses in criminal justice settings, then that could be a helpful first step to educate your team members and leadership on exactly what trauma is and a more comprehensive approach to trauma. And then that would build the foundation for a more specific conversation about drug testing. So thank you, Sam. Sam Rogers just dropped the link that goes directly to the trauma training page, and you can click on the state and find who in your state has been trained in this specific training. So they're certified to provide the training and connect with them. The other option is to reach out to us here at the Gaines Center, and we're also happy to connect you with resources connected to related to trauma. So yes, I really appreciate the comments here. Looks like we do have some folks with expertise in toxicology and drug testing. So thank you very much for chiming in here. And that's the beauty of this Gaines webinar, is that folks with all kinds of levels of expertise are sharing their knowledge. So we really appreciate that. Okay, let's take a look at a few more questions before we start to wrap up. Let's see. So someone did ask, again, related to the best practice standards. This person said they thought that the best practice standards recommended not using multiple types of testing. So they were wondering, does this override that, or is that correct? What are your thoughts on that?
Yeah, so the best practice standards that were released in April of 2025. So you have to go to the most recent best practice standard on drug testing. Again, April of 2025. Explicitly encourages using different technologies particularly for this population. So there, in one of the slides, I had the two paragraphs pulled directly verbatim out of the best practice standards of All Rise 2025. And it says that for a trauma-informed population, for a trauma history population, that they encourage the use of unobserved methodologies and other types of drug testing methodologies to ensure that there is no potential re-traumatization. So I agree. Previous versions of the best practice standards were very explicit about methodology and the number of drug tests and that kind of thing. But our field is evolving. Treatment court world has been evolving for 30 years and 35 years. And it is, this is just, I think, probably one of the last areas where we really need to evolve and explore and research and see what works and what doesn't work for whom.
That's great. Okay. And so the last couple of questions we'll cover. So folks are asking, where can we find research on this? Does this cover youth populations such as teens? And as I recall at the beginning of the presentation, you said that as of 2 years ago, searching the terms drug testing and trauma-informed didn't produce anything. So is that still the case?
Yeah, to my knowledge, there's not been any research on this whole subject. Dr. Philip Breitenbucher, Dr. Jerry Middleton, and myself are the only ones that have published on this topic, and it was all commentary. It wasn't research oriented. So to the researchers on this webinar, the researchers, we urge you to ask and explore the open questions and to research how to do this right. In the meantime, we need to try things and try different things and keep sharing what works and what seems to work. And I think that people with trauma histories need to have a pretty significant voice in this conversation as well.
I really appreciate that. That is so important and such a critical part of each of the courts represented on this webinar to really think about who in your community could be tapped as an advisor to help you all think through what might be the next best steps for us. As Wes said, we're kind of starting the conversation, and it really is going to be an opportunity for the courts to try out different solutions and to explore what works for them and really seek to implement a truly trauma-informed court environment. So we will now move over to some of our closing slides. And Wes, I just want to say thank you so much. We couldn't have had a better presenter. We really appreciate your time and the stories that you've shared, as well as the sense of history you've had in this field. It's been an honor to hear from you. And we do have a certificate of attendance that will be dropped in the chat. Thank you. Sam Rogers just dropped a link. You can click on that. It will, your device will then give you instructions on downloading that to your device, and you will personalize it yourself. You will put your own name in there for your use. Next slide, please. And we do have a closing poll popping up. If you feel led to provide more input or feedback to us, we would welcome that. And as I promised, this link will lead you to the Gaines website, but it will specifically lead you to a place where you can sign up for the Gaines listserv, where you will receive notifications about future webinar events, newsletters that we produce on a quarterly basis, as well as other opportunities coming out from SAMHSA's Gaines Center. And thank you, Wes. Wes did share his email address for those of you interested in, oh, I'm sorry. that went to just the hosts and panelists, West. If you
Oh, I'm
want
sorry. I'm
That's
happy
okay.
to share my email address, westhuddleston, my name, @gmail.com.
So here we go. I'll drop it down. If you do have further questions, reach out to him and we can move to the next slide. Or you could reach out to the Game Center as well. We are happy to answer questions. We have a toll-free number here. If you call that number with your question, you will get directed to the right person. We do offer phone-based technical assistance to communities that are looking for support across a wide range of topics. So feel free to also reach out to us here at the Game Center. And so thank you all for your time, for joining us today for this important topic. And thank you, Wes, for being with us here at the Game Center, letting us be a part of starting this conversation. All right. Have a great evening, everyone.